Welcome back. For you guys, this will be Thursday night. I'm continuing on our lectures on trauma, the bread and butter of what we do in EMS, with the exception of medical. But we're going to talk about patients with spinal motion restriction, patients with spinal trauma. We're going to talk about anything pertaining to the spine at this time. So the PowerPoint you have in front of you is loaded on Blackboard as well, so you have access to it anytime you want to. Okay, so the objectives, we're going to talk about some of the normal anatomy and physiology of the spinal column and spinal cord. We're going to talk about spinal motion restriction, which used to be called spinal immobilization, and, its relationship to patient safety. We're also talking about elements of injury, history, and assessment. And we'll talk about the patients that benefit from spinal motion restrictions and the ones that do not. Okay, we're describing at least one mechanism of injury where spinal motion restriction can cause a significant decrease in survival, and we're explaining the difference between emergency, rescue, and rapid extrication techniques and describe the appropriate utilization of each. So, using clinical evaluation, we're going to differentiate neurogenic shock from hemorrhagic shock. And remember, neurogenic shock is a widespread state of inadequate tissue perfusion from profuse vasodilation. Hemorrhagic shock is the widespread state of inadequate tissue perfusion from blood loss. Hemorrhagic shock and hypovolemic shock are very same, if not similar, whereas hemorrhagic shock is a form of hypovolemia, but not all hypovolemia is from blood loss. Okay, spinal trauma, very devastating, life-threatening. You need to assess these patients because obviously our assessment base is what we do in the field. And we need to determine what course of action would be best suited for the safety of the patient without exacerbating further issues. Our spinal column, if we look at it, it's divided up into several sections. We have a C-spine, or cerebral vertebrae, thoracic, lumbar, sacrum, and coccyx. We have total number of vertebral bodies. We have 7, 12, 5, 5, and 4. If we look at the spinal process here, we'll see that the spine is it's designed to protect the spinal cord, and it allows also for flexibility, but also rigidity to maintain an upright stance, so as much needed. But separating each one of these vertebral bodies is a vertebral disc, which cushions between one another, and a lot of these issues happen as a direct result of that. So, when you look at the spinal cord primary purpose is to take messages from the brain, which is the central nervous system, through the spinal cord in the spinal column to the peripheral nervous system, which sends messages to the rest of the body, and in turn takes messages from the body, returns it to the brain. If we look here, the inside of the vertebral body is where the spinal cord comes through. And if you see there, it's very easy to have a bony prominence fracture and encapsulate that spinal cord, leading to deficits. And wherever your deficit is at will lead to wherever your injury is will lead to whatever deficits you may have. So, different types of spinal injuries. Hyperextension means to bend your head back rapidly. Hyperflexion, as we see this gentleman falling down the stairs there, is excessive anterior movement of the head. So chin to the chest is hyperflexion. Compression is downward. You land on your head, something heavy falls on you. A rotation is where you have twisting of the spine, which is very devastating. Lateral stress, remember, medial is to the middle, lateral is to one side or the other. And distraction means separating or stretching, like we see here with someone who has hung themselves. So, model spinal cord care system, U.S. 40 per million persons per year, 250,000 living survivors, 4-to-1 male to female ratio, 50% are 16 and 30 years old. Children with being motor vehicle collisions being the leading cause, and over 65% of those injured were not wearing any type of seatbelt. Cervical cord was the most common site. And if you think about it, that's the most least protected. We have this big heavy head, then we have the rest of the spine that's supported by our other areas, but then that cervical spine is very vulnerable to flexion extension injuries or distraction injuries. So blunt spinal cord injury takes a lot of force unless there's pre-existing weakness. You have people that have severe arthritis, the elderly, people with osteoporosis, things like that, different bone density disorders. Sudden movement of the head or trunk, frequently injured in more than one place, spinal cord involvement. So column injury, spinal cord, 14%. With the cervical region, it's up to 40% of spinal cord involvement. So quite a bit when you have spinal trauma to the cervical region. Signs and symptoms, pain is the most common. So a lot of times it can be masked by other injuries. So someone might have back pain, but also have a fractured femur, or they might have abdominal trauma. Okay, they may have back pain with or without movement of the back, tenderness along the spinal column. Also remember that back pain can also be caused by retroperitoneal issues involving the kidneys, and loss of blood in the retroperitoneal space could be very devastating. Obvious deformity or wounds of the spinal column, they have paralysis, they have weakness where it's weakest, paresthesias, they have trouble moving certain parts. So primary damage happens at the time of the force. So the spinal cord is either cut, torn, crushed, blood supply cut off. At this point in time, that damage is usually irreversible when that happens. Secondary damage happens after time of force. So it could be hypotension, hypoxia, blood vessel injury, swelling, compression from hemorrhage. Good pre-hospital care could help prevent these things. If we look at different cervical, we look at the spine here, we'll see where the neck looks very abnormal and has issues in there. Neurogenic shock. Shock is a widespread state of inadequate tissue perfusion. Therefore, neurogenic shock comes from spinal cord shock. Signs and symptoms are high space shock, is another way to call it, because it's a state of vasodilatation. You'll see hypotension, normal skin color and temperature because they're vasodilated. Sometimes even appear reddened and warm. They may have an inappropriately slow heart rate, but when we see a slow heart rate, and we're thinking head trauma, remember head trauma, you have hypertension and slow heart rate. Spinal shock, you may have hypotension, low blood pressure, and a slow heart rate. Diagnosis of exclusion, so you got to rule out all types of other stuff because they could have both hemorrhagic and neurogenic problems, so we need to rule both out. So your primary secondary survey is just like anything else, scene safe, got your body substance isolation on, spinal motion restriction. Can they check motor? So can they move their fingers and toes? The sensation, if you touch your toe, can they feel you touching it? Are they unconscious? If they're unconscious, we could try a painful stimuli, see if that arouses them. If not, they could have flaccid paralysis, which means no reflexes or withdrawal, and that's a significant injury. Mechanism, blunt trauma above the clavicle, diving accidents, motor vehicle or bicycle accidents, fall, stabbing or impalement in your spinal column, or shooting or blast injury to the torso. Any violent injury with forces acting on the spine includes the spinal injury. Patient complains of neck or back pain, numbness or tingling, loss of motion, weakness. Don't minimize that. Just because the patient says, well, my neck hurts, but I think I'll be okay. My back hurts, I feel okay. Remember, there's other types of things that refer pain. So you can have a liver injury, you can have a splenic injury that could refer pain to the neck or shoulder or back. You can have a retroperitoneal issue. So there's other things that can cause neck or back pain in addition to a spinal injury. So, but don't rule those out. Loss of motion or weakness we see. Signs are revealed during assessment. Pain on movement of the back or spinal column. So generally we don't want them to move much. Obvious deformity of the back or spinal column, we don't want to move at all. Guarding against movements, this person doesn't want you to move them at all. They'll literally guard and don't want you to elicit a painful response. Loss of sensation, weak or flaccid muscles, including, weakened or absent sphincter tone. Loss of control of bladder or bowels, erection of the penis, which is considered a priapism, which is a non-sexually induced erection caused by spinal injury. And neurogenic shock was a widespread state of inadequate tissue perfusion, so unable to get adequate oxygenated blood supply to the brain and vital organ due to the high space shock or the relative hypovolemia. Spinal motion restriction means to restrict the movement, so you don't want to aggravate the injury. No device has been proven more effective. Um, Spinal motion restriction success depends on application process. Modification, you always need to make your equipment fit your patient, not your patient fit your equipment. Okay? Immediate danger of death, critical degree of ongoing danger that requires intervention within 1 to 2 minutes. That's when we modify. We may have to do a rapid extrication. Let's say the scene's becoming unsafe and you need to jerk someone out of a car. Obviously, you're not going to take the time to use long spine board or KED vest or all that stuff. You're just going to grab them and pull them out if need be. There's many methods of doing so, including using a spine board. Emergency rescue, reserved for immediate within seconds. So these are ones where you get them in a safe area that minimizes risk. That's something that's going to be done. Rapid extrication is considered for medical conditions, situations require faster intervention to prevent death, 1 or 2 minutes, but not seconds. So, neutral alignment. Technique may vary, however, the principle is the same. So, with children, you notice you put a towel or a little blanket under their shoulders because their head's significantly bigger than their bodies to keep it head in a neutral position. This child here is able to keep the head in neutral position. This person here has bigger body mass. They have to put a towel under the head to keep the head and the neck and chest in a neutral position. So, your goal is to keep them neutral, not to hyperextend or hyperflex is our goal. Log roll, single unit, spinal column, head pelvis, patient lying prone supine. Modification required. You want to roll them onto the uninjured side whenever possible. So if someone's got multiple broken bones on their right and none on their left, you don't want to roll them on the side that has all the broken parts. Unstable fractured pelvis. These patients use a scoop stretcher, where if you've not seen one, it looks like a backboard that separates in the middle. And plus, when you have these patients, you want to lift carefully and use 4 more rescuers to carry them on backboards when at all possible. Spinal motion restriction devices, we have a lot of different things. We have our Kendrick extrication device, which has the leg straps and chest straps, and also the short spine board with C-collars. These are used very similarly. The short spine board is kind of the precursor to the KED. Not used a whole lot anymore. Still done in some places. Sometimes you see them around swimming pools and places like that. The KED vest is used for someone who has a possible spinal injury, who is relatively stable and able to get into this vest, which will stable the neck and stabilize the spine. One thing that can be done as far as modification with that said is you can invert the KED vest and put the wide side at the hips and the small side at the feet to immobilize the lower extremities. If you have someone who has like bilateral femur fractures or an unstable pelvis or hips. This here is a rescue type backboard, and there's a PD board which was designed for pediatric patients. There's a lot of different devices, they all work about the same. Complication of the spinal motion restriction is that, one, once you immobilize them, you're responsible for their airway. So if they start vomiting, their head and airway is in a fixed position. You have to be able to have suction ready. You are responsible for their airway. Head and low back pain, I'm a director of being on the board. So patients will complain about the back of the head hurt. They might complain of low back pain because we're not designed to lay perfectly flat like that. Life-threatening hypoxia. So patients that are very obese, they have what they call Pickwickian syndrome, whereas their body mass is unable to be lifted by the chest wall. This leads to basically almost a form of asphyxia. Congestive heart failure. These patients who don't normally lay flat at all are now flat on a board. So sometimes we need to modify how we do things. Also pressure sores. So uneven skin pressure can cause breakdown. And you'd think that'd be a late sign, but if you have someone who already has, let's say someone who's elderly at a nursing home that's fallen and already has some very friable or frail, very easily damaged skin, it doesn't take very long to develop a pressure ulcer. Okay. Complications of spinal motion restriction, injury to rescue personnel. So the more you lift someone, the more obviously you're going to be at risk to back injuries and things like that. However, we should always lift with our legs, not with our back, and we should normally have enough people there to accomplish the lift safely. Okay. Delayed scene time, penetrating chest to the chest and abdomen. Okay. If it's not proximity to spine or no symptoms, you know. Um, so the bottom line is here at the bottom, spinal motion restrictions only apply to those who may benefit and avoid if not necessary. I will tell you that generally most patients can do with if they have neck pain, which is the C-collar by itself, as long as they're reliable and they're able to comprehend what's going on, and they are able to understand what you say to them and able to be assessed. Other patients do require full spinal mobilization or spinal motion restriction. Be familiar with your local protocols. I will tell you that current literature suggests very limited use to no use of backboards other than as an extrication device. However, a lot of hospitals you go in and out of, the doctors still think everybody should be immobilized, so you might get some pushback if you bring someone in immobilized. But as long as you err on the side of the patient, there's not an issue. And there's still, with trauma centers, like in our area in St. Louis, are still wanting patients to be immobilized prior to taking them on transfers, which I can't figure out why they're doing that, because it's not what they recommend. However, you may hear someone say, they're only going to take them if we re-immobilize for transport. If that's the case, can you transport them safely? What's the distance of that? And you want to convey these risks to the doctor, because the doctor, if you have a doctor who's only working like one weekend, may not know how distant the hospital you're sending a patient to is. Controversy of spinal motion restriction. Paramedics are generally all or not never people at times, type A. Generally believe spinal motion restriction should be done until injury is ruled out. So what this means is you want to go ahead and manually secure C-spine until you rule out major issues. Okay. There's a main protocol which is in this PowerPoint set you guys can look at. Or is there no solid evidence class 1? There's been studies done. So spinal motion restriction has historically been done based on logic, not science. So it's like, well, do we suspect it should be done? Then we should do it. It doesn't say, well, scientifically, let's evaluate the risks versus benefits of doing this and that. And it's been studied at length in the past several years. Patient-centered spinal motion restriction requires a clinical indication. It's like any other procedure we do. However, you want to look at the mechanism of injury, but you also want to look at the assessment. Is there pain? Is there tenderness? Is the trauma blunt? Is there ultra level consciousness? High energy mechanism injury? Okay, people can't be assessed clinically. So remember, spinal mobilization is a spine splint, just like anything else. We immobilize the bone above, bone below. So it's a spinal splint that requires, once placed on it, you need to check circulating sensory and motor before and after putting them on it, and they require constant monitoring once they're on it. So very, very important stuff. Spinal motion restriction situations, low risk situation. This would be a patient with a very low mechanism. I'm not complaining of any pain. Maybe complaining of some slight pain. Spinal motion restrictions not required. You have your high risk situation. Could be a motorcycle collision. Could be some very high force situation where spinal motion restriction is performed. Uncertain, we manually stabilize and assess for signs of spinal injury and determine if it's required. And that determination is based on your assessment. I do want to urge caution, especially if you have short transport times to the hospital, that if you have any doubt in your mind that there's a significant spinal injury, or you suspect it, and the risk the benefits outweigh the risks, then you should mobilize those patients. I know some of the paramedics out there will tell you that it's either all or never, but there's very few things we do that all or never is ever correct. We take multiple choice tests. Normally always or never answers are the wrong answers. This is our protocol, which goes through what we basically talked about. It's not anything used in our area, and it's not anything that's national scope of practice. Spinal motion restriction decision. Is the patient reliable? Are they calm, cooperative? Are they sober? Are they not intoxicated? Are they alert? Do they have no distracting injuries, meaning the person that's not complaining of back pain, do they have a femur sticking out? An unreliable patient, is acute stress reaction, someone who's literally kind of freaking out on scene. I have a head brain injury, altered mental state, intoxicated with drugs or alcohol, or have distracting injuries. Airway interventions. Okay, patients lose the ability to maintain their airway to some degree when they're immobilized. You have to assume that responsibility. Airway manipulation causes spinal column movement. So we want to look at the risks versus benefits of this. If this is someone who is going to have an airway issue laying flat on their back, then that's not obviously the right thing to do. Close space rescue. If you're not trained to do it, you shouldn't be involved in that. Safety is first priority, in line with long access, and people should be specially trained for that. Water emergencies. If you cannot swim, do not get involved in a water emergency. Don't go jumping into water if you cannot swim. Okay? Unless your feet touch the bottom, I guess would be the one exception. But backboard is basically you hold C-spine and the backboard is floated under the person. And then you remove the patient from water. Prone or seated, minimize movement. This shows the use of the KED vest. Someone needs to hold C-spine while this whole process is going on. C-spine will be held whenever you do spinal mobilization or spinal motion restrictions on all patients until the procedure is completed. Here's an example of pediatrics. Pediatrics should be transported in a car seat. It is important to know that the car seat the kid was in, if it's a motor vehicle accident, cannot be used again because the integrity is compromised with that. The elderly, here's an example of someone who has a kyphosis or a hump, and this is a case where the equipment was made to fit the patient, not the patient made to fit the equipment. So very important, do it right and do it right the first time. Protective gear, people have football helmets. It's always good to meet with athletic trainers in your area to know what equipment they use. A lot of times athletic trainers will have these off. With a football helmet, remove the face mask. The airway is hard to be controlled. It doesn't hold the head severely. Helmet prevents stabilization. To some extent, the newer helmets are really formed to hold that head in place and are generally left in place. However, if you do take the helmet off, the shoulder pads need to come off as well. You can't take the helmet off and leave the shoulder pads on. So, cut the chin strap. Don't try to unhook. You shouldn't manipulate the person any more than possible. And it's always a good idea to train with people in your area. Most high schools have athletic trainers, very professional teams in your area. You should generally get with them and see how they want and practice how to do that. Protective gear, shoulder pad removal with helmet removal, neutral alignment. So it's fairly easy to take those off. Motorcycle helmet removal. If they're not fitted to the patient very well, if there's significant neck flexion, full face or open face, remove the helmet if you have to manage the airway. In this case here, obviously you can't manage the airway, so it's full face shit needs to come off. There is a procedure that requires 2 people. Okay, so we'll practice that when we get back to lab. Penetrating head wounds do not need spinal motion restriction. So if someone is stabbed in the head, they don't need their neck immobilized. Okay, obese patients, they need to be specialized equipment. You should know the rating of your equipment. Prevent respiratory compromise. If this person never lays flat, you may need to immobilize them in the position that they're found. Hand elevation, upright position. Do not lay someone flat on their back that cannot move their chest wall with themselves. Neck wounds, cervicollar, it may prevent ongoing exam. It may compromise airway with subacute air. It may expand hematoma or mandible fractures. So be very, very careful. You can use other things because remember, spinal motion restriction or immobilization means to remain immobile. It doesn't mean to put a collar or blocks or board. It just means to remain immobile. And any way you can maintain that immobility is appropriate within reason. Um, Unstable or incomplete spinal damage is not completely predictable. You should always base your treatment on your assessment. Remember, treat the backboard like any other splint, like a spinal splint. If you're going to mobilize, always check neurovascular tone before and after and ongoing after that. We always want, remember, we take someone's airway, we need to be able to protect it so they can't protect it themselves. We need to have suction ready. And remember, spinal shock is a form of vasodilatory shock. So it's it's from having inadequate volume in the right spots because you have vasodilatation. So always keep these things in mind. Remember vertebral bodies and the spinal cord's function. Remember we have 7, 12, 5, 5, 4 as far as number of vertebrae between our 5 sections. So keep that in mind. Like I said before, if you have any questions, feel free to text us, email us, call us, any way that's appropriate. You guys have a good night. Be sure to do your discussion boards and your online homework and your offline homework.